Hello and welcome to another Piper Pod. Today we're going to continue with wound care and we're going to have a look at skin assessment. So this particular lesson is going to focus on the generalized assessments that we conduct on skin. It's going to look at what's normal, what's abnormal, and characteristics of the skin that we can utilize in order to best define the overall health of our patient's skin before moving into more specifics of wound care. So what we'll start with is we'll look at the normal changes or changes throughout lifespan. So we'll start with the acutest and somewhat most difficult lifespan, and that is the newborn skin. So newborn skin is unique in a lot of ways, and it's not really hard to see why. So when a baby first comes out, it's covered with vernix. That's what you're seeing on the picture in front of you. Now this is a white, cheesy, odorless substance that is composed mostly of sebum and desquamated epithelial cells, and it covers the skin basically when they're in utero. Now when the baby is delivered, it takes about 24 to 48 hours after birth that the vernix will start to get removed. Now it's best just to leave the vernix on and don't move it with any cleaning substances or extra friction or anything like that. It's actually very good for the baby's skin. Other characteristics you can see is they can be quite cyanotic. Okay, a condition or a presence known as acronocyanosis. Now this is usually found on the hands and feet, and it's got to do with vasculomotor instability. It's also capillary stasis and the fact that newborn babies have an increase in hemoglobin as well. Other things you can find is fine hair all over the baby. So the forehead, the buttocks, in the ears is normal, okay, and it will generally disappear as well. A common skin conditions that baby have is jaundice, okay, because of that increase in hemoglobin that we spoke about before. As those extra number of red blood cells begin to die as a result of not needing to have a higher concentration to take oxygen from mum, you obviously have an increase in bilirubin. And sometimes this bilirubin can be hard to process for the baby, so they appear to be jaundice. Other quite abnormal signs that you can see on a baby can be the presence of harlequin color changes. Now this sign may be observed in infants that's lying on its side. Now when that happens, the lower half of the body tends to be pink and the upper half tends to be pale. Now the color changes develop suddenly and can last for around 30 seconds to 20 minutes. Okay, so there's no real hard and fast. It resolves with an increase of muscular activity, and it can affect about 10% of all infants, usually in the 5th day of their life, up to 3 weeks. Now it can be quite off-putting, it can be quite scary, but it's not really dangerous in the short term, but it can be caused by an immaturity of the hypothalamic centers. So sometimes it's something that requires further investigations. The last thing that you'll find on babies quite often is birthmarks and hemangiomas, like your stork bites and things like that. Now we'll look more into hemangiomas and things like that later on, but they're just the starting point of what's different with our newborn bubbies. Once we move on and we look at children, the younger children's skin, there's nothing really unique, nothing really different that occurs in the early childhood stage as far as skin goes, and most of the things that you treat as far as children goes is things exposed to, infectious diseases, trauma, and stuff like that. Once they move on to pubescent skin, then obviously we get a lot more changes with the hormonal developments. Now again, we see the infectious diseases and trauma, but this is where we also have the increase of acne. Now, acne has 4 grades in which you can classify it. So it goes from grade 1, which is just the presence of decent blackheads, all the way up to grade 4, which is the presence of widespread cysts and scarring. Okay, so you go from simple blackheads all the way up to cysts and scarring when you're dealing with acne, and it can be quite difficult to treat and usually comes with a higher probability of infections. Another time during a lifespan that has significant changes to the skin is during pregnancy. Now, there's a few generalized changes that occurs. Obviously, in the body shape and size goes through some significant changes, but the skin can also be affected too. So one thing that you can see is a thing called linea nigrae, or pigmentation of the linear line during pregnancy. Now, this appears as a dark line between the two abdominal muscles. So the erectus abdominis, it'll actually get a darkened line in between them. You can also get strabes, which is also known as stretch marks, and a generalized changing of hyperpigmentation across the face. Now, the last age group we'll look at will obviously be our elderly. Now, during middle to advanced age, the skin goes through many changes, which I'm sure is not a big surprise to anyone listening. Now, usually due to a systemic decline and environmental exposure, thinning of the epidermis occurs. Okay, the dermis also atrophies and contracts, and there is a decreased vascularity within the dermis itself. Now, the skin also decreases in turgidity and has a reduction in collagen and elastin fiber production. So the collagen presence becomes thinner, and when combined with a decrease in adipose tissue, the skin support structure is compromised, and that's what causes the wrinkles. Now, the skin on the back of the hand can also become thin and transparent, and as a result of all the things mentioned, they're more likely to get bruises and lesions and keratinosis, skin tears, nevi, all these sort of things they're more likely to get. You can also get color changes as a result of pigmentations and the presence of lesions that affect the peripheral circulation as well. Okay, now that we've looked at the different characteristics across the lifespan, we'll move on to looking at skin assessment. Now, a lot of people pay lip service to a good skin assessment, but it can be very important. So a regular and comprehensive assessment of a person's skin is very important because it provides relevant information about the person's age and state of physical and emotional well-being. It can also have links to cultural and lifestyle pursuits as well. It makes it easy to identify vascular alterations in things like primary and secondary lesions. It also dictates and evaluates management of the skin as well. So a skin assessment is just like any other assessment. It always starts with a good clinical history before moving on to the physical examination. So it's clinical history, then inspection, palpation. From those three things, recommendations for pathological analysis like biopsies or skin scrapings can be recommended. But the clinical history should be a comprehensive clinical history, and it should have records of your medical, surgical, obstetric events, and any relevant changes the patient has noted in the integumentary system. It should identify any environmental, chemical, mechanical, dietary, allergies, medication changes that the person is having, and the impact of those things on their skin. Okay, so that's generally what we're looking for when we go through our clinical history. From there, we move on to our inspection. And the first thing to look at will be the color of the skin. Now, the color changes in the skin can result from physiological response or perhaps a result of a chemical such as dyes. But there are certain colors and pigment changes that some sort of pathological response, and they are your erythema, cyanosis, pallor, and jaundice. Now, if you look at picture 1, erythema occurs with vasodilation of capillaries in the skin as a result of blushing, temperature changes, thermal, or an inflammatory response. Now, inflammatory can be a result of the normal healing process or the presence of an infection. When we move on to cyanosis, denoted in number 2, cyanosis is caused by a decrease visibility of oxyhemoglobin and an increase in unsaturated hemoglobin secondary to hypoxia. it can indicate an obstruction of the airway or obviously a cardiovascular or pulmonary disease. Now, white skin, seen in number 3, can be caused by a lack of sun exposure or the absence of melanin such as albinism, but pallor itself may be caused due to shock, anemia or arterial insufficiency. And as seen in the picture, a good place to check for things like shock and anemia is the inside of the eyelids to see if they actually have a red tinge to it. And the last one, number 4, yellow coloured skin changes indicative of either an increased bile caused by damage or obstruction to the hepatobiliary system, or an increase in keratin pigmentation due to an excessive intake of vegetables that contains keratins, like your carrots. After we look at general colour changes, we can start looking at specifics, vascular alterations. Now, 2 quite common vascular alterations is petechia and purpura. Now, petechia is a red or purplish discoloration that's less than 0.5 centimeters in diameter, or best as diameter as you can. And when you put pressure on it, it doesn't have any blanching. Now, a purpura is the same thing, it's just larger than 0.5 centimeters in diameter. Other vascular alterations can be as simple as bruises. So bruises is obviously a discoloration caused by vasculitis or trauma. Now, as you're aware, the colour of a bruise will actually change depending on how many days it is present. It's got to do with the breakdown of the actual blood outside of the vascular space. So it goes from a very keen red colour through your blues, dark purples, pale green on the outsides before it turns to yellow and brown. So look out for the colour of your bruises to denote how old they may be. Now, hemangiomas, things we mentioned just before, they're birthmarks. Now, whilst they look quite large and can look quite grotesque sometimes, so they can be cherry, port wine in colour, but generally they fade within approximately 2 years and they're not really that debilitating. So they look grotesque, but there's really not much to worry about. And the last 2 that we can look at as far as vascular alterations is your spider angiomas and your venous star. So your spider angioma, based on its name, has a spider-like appearance and can occur on the face, the arms, trunk, or even around the neck, and they're usually associated with liver disease, vitamin B deficiencies. You can also get it in pregnancies as well. Now, these particular lesions, they blanch with pressure. So if you put pressure on it, the colour actually goes away. Now, venous star is pretty similar, but is named because of its linear pattern from a central point. Now, this occurs due to dilation of superficial venous vessels and capillaries, and is often observed in people with varices of the legs. These lesions do not blanch under pressure. Okay, now that we've covered off on your vascular alterations, we can move on to your lesions. Now, a lesion is any pathological or traumatic manifestation that interferes with the continuity or the integrity of the skin. Now, a lesion is either defined as a primary, when they are a manifestation of a pathological process, or a secondary, when they have evolved from a primary lesion. So in the picture in front of you, the areas that are within the dotted red boxes are primary lesions. Now, you can break those down further again, and you can start with your non-palpable coloured lesions, which is where your macule fits in. So a macule alteration of the skin colour that is up to 1 centimetre. If it grows larger than 1 centimetre, it's called a patch or a Mongolian spot. Okay, from the non-palpable, we can move into palpable solid lesions. So your wheal is often caused by an insect bite or hive, and is a raised, irregular transit area of skin oedema. Now, your papilla is a solid raised area that's up to about 0.5 centimeters. If it's bigger than 0.5 centimeters, then it becomes a plaque, and that's more of a solid raised lesion. Now, to make things more confusing, if it's not a papule or a plaque, it could be a nodule. Now, a nodule is a raised, firm, circumferential lesion that is often deeper and firmer than a papule itself. Now, last category that can fit into primary lesion that's a palpable solid lesion can be your tumours. Okay, raised lesion that's generally larger than 1 to 2 centimeters, also known as a neoplasm. From your palpable solid lesions, we can move on to the last category, which can be your elevated fluid-filled lesions. Now, this is where your vesicle fits in. So a vesicle is filled with serous fluid that's less than 0.5 centimeters. Okay, if it's greater, then it's called a bulla. Okay, so a bulla, serous fluid greater than 0.5 centimeters. Now, a pustule is essentially a vesicle, but it's filled with pus. And the last one that fits into the same category can be your cyst, which is like the other ones, but it's filled with fluid or a semi-solid matter. A very common one is your sebaceous cysts. Right, moving out of the box, we'll move on to our secondary lesions, and we'll start with our erosion. And this is simply just a loss of epidermis, leaving a depression. It usually has a moist surface with that as well. Now, a crust, on the other hand, is a dried serum, pus or blood, which is often called a scab. Scales is a flaky or exfoliated epidermis, commonly dandruff or your psoriasis itself. And a fistula is a linear crack that extends through the epidermis into the dermis. Okay, a few other things that fit in the category of secondary lesions include your ulcers and your exonerations, which is a loss of epidermis, leaving a linear patch mark, much like a scratch or an abrasion. Another very important thing to look out for when we're dealing with inspection, and sort of branches a little bit into our palpation, is our oedema. Now, oedema is an abnormal accumulation of fluid in the interstitial space, usually a result of the body's response to obvious swelling of tissues. Now, oedema is assessed according to its location, shape, and colour. The normal colour of skin can be difficult to assess in the presence of a marked oedema, because the distance between the outer epidermis layer and the pigments of the vascular layer of the skin is increased. Okay, so it can be quite difficult to find. Clinical assessment is used to determine the degree of oedema. Now, this can be difficult, and it's often written as oedema with a series of pluses afterneath. So 1 plus is, as you see in the picture, they say 2 millimeters, can be difficult to gauge, but it's a slight indentation with normal anatomical contours. If we move on to plus, it's a deeper indentation, okay, about 4 millimeters, which lasts longer, and plus with fairly normal contours. Okay, so it's still relatively normal. Moving on to 3 pluses, it's a deeper indentation, which remains several seconds after the pressure with obvious swelling. Now, 4 pluses is the deepest indentation, and it will remain for a few minutes, and it has frank swelling. So when we get around the 3 and the 4, this is when we start moving into pitting oedema. Now, another type of oedema is our Brauning's oedema. Now, that is said to exist when the tissue cannot be indented at all because of the excessive intracellular fluid amount. So generally, when that's the case, the skin is very shiny and very firm, and the anatomical contours may be completely distorted. Okay, we'll finish this presentation up and we'll have a quick look at our palpation. So when you're palpating the skin, a good thing to take note of is obviously the moisture, temperature, texture, turgor, and any lesions as well. So if there is moisture on the skin, the source of the moisture needs to be identified and the consistency determined. If it is thin, watery, oily, or thick, okay, all different characteristics. Now, if it is lesion fluids, that fluid needs to be examined for colour, amount, odour, and consistency. If during your palpation you detect a change in temperature, then it needs to be noted. Now, generalised skin temperature and localised changes can be noted. Localised increase in temperature can be due to inflammation, infection, or just simply overheating. Now, a decrease in temperature could be due to a disturbance in circulation, shock, or the exposure to cold. Texture relates to the thickness, smoothness, or roughness of the epidermis. It is normal to find that exposed skin or skin on a major working surface of the body will be rougher than the texture of an unexposed skin surface. Okay, so the outside of the arm compared to the inside of the arms, for example. Now, various lesions will affect the texture of the skin, as will some activities of daily life. Now, turgidity describes the elasticity of the skin and its ability to rebound following compression. Now, turgor is influenced by the state of hydration and, of course, the age of the person. As mentioned before, an elderly person has decreased elastin deposits, and therefore their turgidity can be affected. And finally, you make any note of the lesions that we talked about. So palpate the lesions to determine their size, shape, and mobility, and if there's any tendency or change in the skin contours and function to the surrounding area. Okay, well, that finishes up the presentation on skin assessment. There is a lot of individual notes to go through, and realistically only going to get better at this sort of thing when you keep doing it, keep practicing it, start using the correct terminology in order to build a bank of these terms, and from here we can move on to specific wounds and we'll refer back to skin assessments. But whenever you're treating someone who has a wound or is going through a healing process, it is always recommended to do a generalized skin assessment as a way of denoting the overall health of the person and the potential hurdles you'll need to jump over in order to optimize the healing process for your patient. The next wound care lesson we're going to move on to is going to be looking at the factors that inhibit healing. But until next time, take care.